Good morning. Powering up. We got Instagram, YouTube. Welcome back to the PT on Ice Daily Show. I'm your host for the morning, Paul Kaloran, and we're talking some dry needling. We out here on the West Coast, super early. Love these shows, but I love them not always at 6 a.m. But thank you for tuning in. I'm going to keep it brief today, and I think there's potential for a follow-up on this topic because I'm not going to take necessarily a firm stance as far as suggesting a second protocol. But the intention of this episode is to somewhat challenge the current narrative that is attached to dry needling post-surgery. So those of you out there that are trained in dry needling, whether you asked directly or it was immediately impressed on your weekend course, how soon can we dry needle post-surgery, or is there any risk? And knowing a lot of the narratives that are out there already, you are probably giving a fairly conservative or an ultra-conservative recommendation not to needle anywhere for a certain period and not to needle local to a surgical site for a certain period. So what I'd like to challenge today is that narrative. And first of all, to explain, I fully understand the current narrative, or I fully understand the intent behind the narrative, and that is not to be potentially aligned with a negative or an adverse outcome, which is a post-surgical infection. So I fully believe that if we don't want ourselves to be implicated at all, or I should say potentially implicated at all, to a post-surgical infection, it's very easy to say, let's not dry needle for a certain period. But I immediately want to tell you this. First of all, we have zero data to suggest that we, with our dry needles, with our monofilament needles, can contribute to a post-surgical infection. Two, I will admit, we live in a very litigious, a very liability conscious culture in the US. So there are certain scenarios where maybe we are more conservative and others where we're not. But I do think we're leaving a lot on the table if we just give a blanket statement of we're not going to use our dry needles on any post-surgical patient for fill in the blank. And some of the narratives out there are we're not going to needle anywhere in the body for 6 weeks up to 3 months. And we're not going to needle local to a surgical site for 12 weeks up to 4 months. So those are the narratives out there. And again, no research to support the risk. I understand why that narrative is out there as far as avoiding any implication liability-wise if there were to be a post-surgical infection. But I have to say, we're leaving a lot on the table. And I'm not going to dive deeply into very specific research this morning, but I'll tell you, there is limited research out there needling post ACL reconstruction, and the inclusion criteria was 7 to 21 days post surgery, and there was good outcomes in range of motion, in quad restoration and atrophy, and there were no adverse events. There's also data where they use it post TKA, so total knee, and again, kind of mixed outcomes depending on how they used it. But what they all say is that there were no adverse events as far as including dry needling earlier on in post-surgical rehab. So that's the table I want to set. Again, today I'm not going to take a hard stance and say we should be needling here much sooner, but I think we need to shift the paradigm away from kind of an ultra-conservative mindset not to, because we're leaving a lot on the table and there are patients we can help by slightly shifting our thought. The first challenge I want to give you, and kind of one thing foundationally I don't like about just this blanket, we never needle for a certain period post-surgery, is we have to understand that different surgeries and different patients are different. And even if we're conscious of the risk of post-surgical infection, we have to admit that there's a big difference from maybe a less healthy, obese, maybe smoker 60-year-old getting a total hip and relatively healthy high school, college athlete having an ACL repair. I mean, if we're applying the same blanket, we would not needle for a certain period to those two patients, that's an issue for me. So the first recommendation I have today, I'm going to give you three just broad topic recommendations. First recommendation is just know the procedure and know the patient. Again, there is a large difference in tissue trauma, in potential risk of a post-surgical infection from a total hip to a knee scope. Similar for shoulder. There's a big spectrum of different procedures where we're more concerned about infection risk. So if you know the procedure, that's important. But I'll tell you what's slightly more important for me is knowing the patient. And that's not just the patient's willingness to have dry needling earlier in the rehab or not. It is general health, general fitness, tissue health, but again, overall health of that patient. Which patient am I more likely to, or am I more comfortable using dry needling earlier than another? It really comes down to general health and fitness. Again, if there's one singular risk that we're concerned about post surgery, as far as our needling contributing to an infection, then we have to kind of stratify that there are more risks to other patients. So I think that's the first recommendation is know the procedure, know the patient. 100% the patient needs to be on board with dry needling. Depending on what setting you're in, maybe it's worth discussing with a physician. But I think if it comes down to us and our expertise and being the provider that's going to apply the dry needling, we can have some flexibility between these two ends of the spectrum. Because number two, I think the paradigm shift that we need to have is maybe dry needling doesn't have to be a first line treatment post surgery. I'm not going to swing the pendulum all the way to the other side and say we should be needling all patients week one following surgery. I'm not there yet. But what I am saying is if it's not going to be a first line treatment, it can't be a last resort. And now I'm thinking, in that not acute, but that subacute phase following surgery where things aren't going well. I mean, for ACL repair, we have quad palsy or just devastating quad atrophy that's not returning. Maybe for total knees, we're talking about those final degrees of terminal knee extension that aren't returning. Same thing for a shoulder. We're going into just poor rehab outcomes, or even worse, that we're kind of developing some adhesive capsulitis. I think when we start to see early signs of that post-surgical impairment, like beyond the normal impairment, that is when we have to start using dry needling. And I guess whenever anyone comes to me and talks about risk of dry needling, like in general, but for this talk, we're talking post-surgical infection, I'm happy to talk about the risks that dry needling might have, but I immediately want to go into the conversation of like, okay, what else is this patient going to do? And if the answer is going under anesthesia for a manipulation, or in the context of quad palsy, extending, having a poor rehab, extending 2 to 3 months beyond normal, I'm personally okay with dry needling being on the table. Let's talk about risks. Let's talk about the data, which really says we're not going to cause an infection, but we can talk about it like as a potential invasive procedure following surgery. But if the alternative is everything else, injections, again, anesthesia manipulations, at that point, I'm okay using needles on that patient. And depending on where they are in their tissue healing, so their post-surgical stage, I'm pretty comfortable going pretty close to ground zero, appreciating that the more acute inflammation and the more acute healing processes is complete. And now we're kind of down the road of remodeling, maybe even into scar tissue. I think if we wait too long, again, back to those ultra conservative thought processes post surgically, I think if we wait too long, even with dry needling, we can't expect immediate or very strong returns. I think we have to do it a little sooner. So that's point number two, is I don't think it needs to be first line, but it can't be last resort, or at least it should be considered before the last resort. And the last thing I'll say here this morning, I'll keep it pretty brief, and then I guess I'll kind of give a segue to a potential future episode, which is how do we use our needles post surgically. Um, Number three is that if we want to talk about the research, I've already said that there are case studies and some certain post surgical patient populations that have done really well. Uh, the research supports it. But if there's still concern for you personally, or if you're in a hospital setting or some other setting, if there's concern to just um, foundationally avoid dry needling for a certain period post surgery, I think we have to look at the research and say there's benefit to pre-surgical dry needling. And again, I'll unpack one study for you. These are total knee um, TKA patients. And in this one study, I'm pulling up right here, they brought the patient in, put them under anesthesia. They're preparing for the surgery. And while the patient was under anesthesia, they did a dry needling treatment to the quads before the surgery. Um, and there was post-surgical benefit to that. So let's find the conclusion here is that that's a different one. Is that they saw improvements in post-surgical range of motion in combating atrophy and post-surgical pain. So, I mean, that's an extreme example. I'm not suggesting everyone's going to go into the operation room and start dry needling. But if you or the patient or you're in a system that is really going to say, we're not going to use dry needling for 3 to 4 months post surgery with this patient just because of any potential risk of infection, then I think we have to consider, is there benefit to pre-surgical dry needling? Um, and right now I'm focusing in on dry needling. Hopefully it's obvious to say we should be doing everything else. There's also massive benefit to pre-surgical strengthening. I think if a patient, not just knee surgeries, shoulder surgeries, low back surgeries, I think if the patient is resigned to having surgery, they come in and say, Paul, I understand what you're saying, that half of us are walking around with rotator cuff tears and just don't know about it, like whether it's painful and limiting or not. But I went and saw my surgeon and he kind of convinced me. So I'm scheduled for surgery. I think at that point, we don't just roll over and say, okay, well, I guess I'll see you in a month or two after your surgery. I think we kind of double down and say, I understand your decision. I understand why you made the decision. The best thing we can do right now, pre-surgery, is we can still use dry needling. Like there's actually good data that we can have better post-surgical outcomes by pre-surgical interventions. But really the bigger thing we're going to be doing right after needling, or the more important thing, is strengthening. So the bigger and stronger you go in, bigger, stronger muscles that you go into surgery is directly linked to how quickly you recover from surgery or your prognosis post-surgery. So I think we can apply that same thought process to needling. If it's like, man, I was really hoping we didn't go down the surgical route, but since we are, I think there's still value to dry needling. So that's kind of shifting it from post-surgical to pre-surgical. But again, I can drop them on social media, or if you're in the ICE group and you want to see some of these specific studies, they seem to be all knee. They're total knee arthroplasty and ACL repair of immediately using dry needling post-surgically. Again, my favorite one is the ACL repair because the inclusion criteria was 7 to 21 days post-surgery. And they saw good outcomes. And to be fair, what they saw is that not necessarily functional strength and like standing single leg balance improved. They didn't see that. They said that was still directly correlated to the typical strength and rehab programming. But what they did see is range of motion came back quicker and there was less atrophy when we used dry needling. So I think this morning I'm going to cap it there. I mean, my recommendation is that we shift the narrative or shift the paradigm of post-surgical dry needling. I don't think it's fair to just apply a blanket, we don't needle for a certain period, and apply that blanket to every patient and every type of surgery. it is a bit antiquated. It is a bit ultra conservative because really we have no data that we can contribute to a post-surgical infection. And really that's the only fear, the only risk is post-surgical infection. My challenge for this morning is number one, know the procedure and know the patient. So know the tissues involved, know the typical healing times, but really, I think more important to me is know the health of the patient, the overall health, which is directly linked to tissue health, tissue healing. The recommendation number two is maybe dry needling isn't a first line intervention post surgery, so it doesn't have to be week one, but it shouldn't be a last resort. I think we have to use it sooner. And again, very specific examples of patients that aren't progressing well with rehab. I think we have to intervene with dry needling sooner for those patients. And then the last recommendation is if you personally or you're in a system that is just going to maintain this very conservative post-surgical needling stance, is there value in pre-surgical dry needling? I would say yes. I would say it has to be directly attached to a strength focus pre-surgically, but both of those interventions having direct carryover with post-surgical prognosis. So that's all I'm going to hit you with this morning. Again, I think there will be opportunity for a follow-up if there's interest out there. I mean, drop comments if you have them now or on social media. And I think the part two could easily be, okay, you don't have to just fully take my word for it, but let's talk about how do we use it post-surgically. I think that's an episode for another time because I'm not endorsing a very aggressive pistoning. And I think we have to be kind of a little strategic and almost algorithmic for if we're going to use needling. We don't go straight to ground zero surgical site. It's how do we progress through the phases of rehab with our needles. But I think that's a topic for another time. I'll pause for 1 minute just to see if there are any comments coming up. All right, folks, that's all I got for you today. Thanks for hopping on. I'll see you down the road on another PT on Ice.